right, hi anatomy students. So this is part 3 of our biomechanics lecture series. The first was on bones, the second was on muscles. This, the shortest of the screencasts, is on joints, and collectively this will all help us put together how we move as humans. We're going to cover joints, how we classify them, the structure of the most typical joint, which is the synovial joint, different types of synovial joints, and then we'll talk about some conditions. So first of all, if we define a joint, we also use a word articulation to define a joint. It's any place where two bones are going to come together. The general function of these joints is that it's going to allow our skeletal systems to come together. It's going to allow us to have mobility because it's going to be the fulcrum of the levers of our skeletal system, and it's going to allow us to have flexibility. So we need joints between our bones in order to move. We need to bind our skeleton together. These joints also allow bones to grow. So we'll talk about specific bones in our skull that grow because of these joints. Joints also permit the skeleton to change shape. So we'll talk about certain cartilaginous joints that will actually change during childbirth, and they allow the body to move in response to skeletal contraction. So let's start with the very basics. There are two ways to classify every joint. We can characterize or classify them by their structure or by their function. So in other words, what are these joints made out of, or what movement they allow? So let's talk first about the structural classifications. So in our body, there are fibrous joints, cartilaginous joints, and synovial joints. The fibrous joints, just kind of like they say, or just kind of like it sounds, they have fibers. They will attach bones together with collagen fiber. Cartilaginous joints, again, are going to attach with cartilage, and synovial joints are going to have a packet or a pocket of synovial fluid that will help to lubricate those joints. The functional classification basically describes those joints in terms of their movement, so their function. So fibrous joints are also known as synarthroses or synarthrosis. Syn means together, arthro means joining. So these types of joints, fibrous joints, do not move. They are immobilized joints. They're just there for support and structure. Cartilaginous joints are also known as amphiarthrosis. So amphi means kind of both sides. Arthro again means joining. So amphiarthrosis means that they move, but only a little bit, usually just side to side. Synovial joints are also called diarthroses, and this means di meaning all directions and arthros meaning joining, which means that these are freely moving joints, much more movable, much less steady and stable. Which brings us to this next point. With all of these joints that we just talked about, whether or not they be the fibrous, the cartilaginous, or the synovial, there's always a trade-off. All right, so if you think about it, the joints in your body that are the most stable, that are the strongest, that they're never going to tear, are also the joints that are the most immobile. If you think about the joints that are the most mobile, think about the shoulder, the hip, those are the joints that have the least stability. So there's a very important indirect relationship between mobility and stability, and that allows us to diagnose some common ailments that are associated with joints. So by this time, you should be able to answer these questions. Since this is a screencast, if you can't answer these, I would go ahead and pause and go back into the slideshow and rewatch that part. So let's look at examples of each different types of joint. So we went over 3, fibrous, cartilaginous, and synovial. Let's get some examples of those. So there are 3 go-to fibrous joints. The first are called fiber sheets, and these are found usually between long bones, and they will connect or bundle those bones together. So there's a very important one that connects the tibia and the fibula in our lower leg. That's the reason why those two bones are separate, but they don't move. They're connected together. Second example of fibrous joints are the sutures in the bone, sutures in the skull. So we saw these when we were studying our skull. You can see that where the bones come together, like our frontal bone or our parietal bones, there's this kind of zigzag meandering line. Those are sutures, and those teeth-like projections actually have connective tissue between them, but that is a fibrous joint. So they're very strong, not a whole lot of movement there. The last type of fibrous joint you don't typically see, and that's because it's in your teeth. So remember, your teeth are living tissue. They have many different layers, just like all of the other tissues we've been studying, and they are connected to the jawbone, the mandible, using this joint called gomphosis, which is another type of fibrous joint. So again, we're hoping that that is a pretty strong connection, that your teeth don't fall out. So fibrous connections, the most steady and the most immobile. The middle ground here is the cartilaginous joints. So there are three main examples of these. The first is in the rib cage. So you can see that the first rib down to about the sixth or seventh rib are all connected directly from the back of the vertebral column to the front of the sternum and the manubrium. Then you have the false ribs that are connected to a piece of cartilage, which then in turn connects to the sternum. But regardless, the rib cage is made out of these bands of hyaline cartilage. So very strong, but allows some movement. If we think about that, that's pretty good. We need to support our ribs, but we need a little bit of movement so that if we ever would have an impact to our chest, the ribs could move, but it would adjust, they wouldn't break. Second example of the cartilaginous joints is the pubis bone. So the pubis bone is made out of, is connected to the ischium and the ilium of the pelvis. But this pubic bone has a cartilaginous joint in between them. And during childbirth and during pregnancy, there is a hormone called relaxin. And this relaxin hormone will actually relax these cartilaginous joints. And if you think about that, that's a pretty good thing because that allows the pelvis to open up so that the child can pass through the birthing canal. The third example of cartilaginous joints you might also have heard of. You might have heard of people having this thing called a slipped disc or a bulging disc in their back, and it causes a lot of pain. And that's because in between each vertebrae, there are these cartilaginous joints that are kind of squishy. That's a really good thing because it allows our vertebrae to be able to move and to bend and still lubricate those joints. It's also a very good thing because every time you run or you walk, you're essentially compacting all of those vertebrae down on each other, and this cartilaginous joint is going to protect them from crunching or crushing each other. So those are examples of fibrous joints and cartilaginous joints. The last category is probably the one that we'll focus on the most, and these are called synovial joints. These are the most freely moving. They are directly related to mobility, and they're the most common to be injured because remember, with increased mobility comes decreased stability. So there are specific parts of these joints. There is always going to be articular cartilage. So that means that on either end of the two bones that are coming together in a synovial joint, there's going to be a thick, strong covering of articular cartilage. And we're going to see that in our dissections a lot. Then surrounding that connection between the two ends of the bones, there's going to be a cavity. And that cavity is going to be filled with this synovial fluid. So it's this viscous, very smooth, very kind of basic slimy fluid that will reduce the friction as these two bones are moving on each other. That synovial fluid is contained by the synovial membrane. We might also see the presence of bursa and menisci, and we'll see them a little bit more in the next slides. So these synovial joints are so prevalent in our human skeleton that we actually categorize them into different groups based on their movement. So we'll go through a couple of them. So the first is a pivot joint, which you kind of figure out is going to be when two bones are going to pivot using that synovial joint. So a great example of that we've talked about a little bit in class is when you turn your head from side to side this way. So it's when your head will pivot, kind of like you are shaking your head no. And it's going to be when the axis provides that pivot point for the atlas to rotate around. So that's a pivot joint. The hinge joint is found a couple different places. It's found in our elbow joint, it's also found in our knee between some of our phalanges. This hinge joint is relatively stable side to side, but it allows the up and down or the flexion and extension movement really well. Saddle joints, this is kind of a cool connection. We see these in our metacarpals, specifically our first metacarpal that makes up our thumb. It's the metacarpal that connects to the carpal called the trapezium. And this allows our thumb to have kind of this very unique movement where it can move front to back and it can move up and down and side to side. We can kind of do it in a circular movement, but it doesn't have much movement outside of that. So that's achieved by that saddle joint. Then we have a condylar joint, and this is going to be between the metacarpals and the phalanges. And you can kind of see that this is when you have two rounded structures fitting together. Again, you can see that in the fingers more. Then we have the ball and socket joint. So this is what I typically think of when I think of a synovial joint. Great examples of this would be the hip joint, where the head of the femur fits into the pelvis, and the shoulder joint, where the head of the humerus fits into the rotator cuff and the scapula. Then we have gliding joints. So these are the joints between all of the short bones that are in the carpals and tarsals. And they slide as we move our wrists and as we move our ankles back and forth. Again, that's why they need to be very short and compact in those areas. So again, let's do a real quick check-in. I'm going to zoom through this because we're in a screencast format, but you are more than welcome to pause this, take a look at these questions, make sure that you've picked up what you need to, and if you're not sure about them, go ahead and zoom back to that part in the screencast. Other things you need to know about synovial joints. Let's talk about the key players that are going to be involved, the structures. We talked a little bit about the synovial cavity that's filled with the fluid, the articular cartilage that's going to be on either side. A cool thing about that is when people talk about getting arthritis, either through rheumatoid arthritis or just in old age, arthritis is the breakdown of the hyaline cartilage. So that's the reason why people's joints get stiff later in life. All synovial joints are going to be surrounded by ligaments. So remember, ligament starts with an L, that means like, so it's going to connect bone to bone. And those ligaments are going to reinforce the synovial joint because they are so mobile. Synovial joints will also be innervated, which means that they have lots of nerves around them, which is the reason why if you take your shoulder or if your shoulder gets knocked out of socket, it's very, very painful because there's a lot of nerves in there. And then those synovial joints will also have blood vessels. Of course, we need to have blood vessels to provide all of the nutrients needed for cell respiration to get ATP and energy. So cool things about synovial joints, a lot of people connect synovial joints with being the joints that hold your knuckles together. The synovial joints and the fluid within those joints, again, that fluid is clear, it's colorless, it's very viscous and smooth. And actually dissolved in that viscous fluid are these teeny tiny little gas bubbles. So you might have heard people crack their knuckles before. The crack comes from when you are pushing that synovial joint and you're putting so much pressure that the gas bubbles, due to the gas laws, as the pressure increases, the gas bubbles will actually expand and they release a little bit of a sound. So there's this really cool old doctor named Dr. Unglar from the University of California, and he basically made it his life work to either confirm or deny that if you crack your knuckles, it will cause joint pain or arthritis. So we're going to watch this real quick clip about cracking knuckles.
Recognize this sound? If you pop or crack your joints, you probably do. What happens to our joints when we crack them? And is it bad for you? Synovial fluid is this lubricant-like substance that's found in between your joints. It kind of looks like an egg yolk. So when you stretch out your joint, you are releasing gas, and that gas forms a bubble and it collapses and pops. In order to crack the same knuckle again, you have to wait about 20 minutes for the gas to return back to that fluid. So how is that different from a pop you hear when you stand up quickly? The sound you're probably hearing then is the snapping sound tendons make when they slide between muscles or over bones. When a joint moves, the tendon snaps quickly over it and it makes a popping sound. So is a knuckle cracking habit safe? Probably. Donald Unger was sort of a self-described researcher who chose to pop the joints in one of his hands for 60 years, but not the other one. And he wanted to find out if popping your knuckles would actually give you arthritis. After 60 years of doing it, he found that he didn't have any more arthritis in one hand than in the other. Most medical sources agree with his findings, but there's still a chance it's not good for you. One 1990 study did find that cracking your knuckles over a long period of time led to hand swelling and decreased grip strength, but there hasn't been any follow-up research on that. So while cracking your knuckles might not be bad for you, there's still no guarantee that your popping habit won't annoy the people around you.
So So there you have it about popping knuckles or cracking your knuckles. Some other joint structures that we'll come across as we're studying these articulations are these things called bursa. If you think about your bones connecting together, it's not just the bones we have to worry about cushioning. We also have muscles that are lining those bones, and a lot of times those muscles will be stretched over the bones. So bursa kind of help us achieve a little bit of cushioning for those muscles and tendons. So they are these tiny little fibrous sacs that are filled with synovial fluid, and they usually just lay on the surface of a bone or a joint that will help them cushion bones, tendons, or muscles. This will help decrease friction during movement, but a lot of times with rapid movement or with some sports, you'll actually irritate the bursa, and so that causes bursitis. When the bursa will actually get inflamed and painful. So bursitis is very, very common in the shoulder. So shoulder bursitis is when you have inflammation of that shoulder bursa, so that every time you move your arm, you feel a lot of pain. So we can treat that through injections of a corticosteroid, there we go, or treating with anti-inflammatories, a lot of times therapy. So if you strengthen the ligaments on either side, strengthen and bolster up the muscles that are underneath the bursa, that helps. In very extreme cases, they'll have to go through and surgically fix that structure. Another structure you may have heard of, especially in talking about the knee, is this thing called a menisci. And a menisci is kind of like a fusion between cartilage and fiber. It is much tougher than most cartilage in that the meniscus is usually weight bearing. And these are meant to cushion joints, but they're meant to take a lot of weight. So if that weight is unequally distributed on the meniscus, it will actually tear because they are fibers. So torn meniscus is very, very common in the knee. We'll talk a little bit more about that. So let's talk about how joints will change over lifetime. So it is true that if you don't use it, you lose it. Joint stiffness is usually what you see as people start to age. They start to get a little bit slower getting up, a little bit slower doing activities. The fibrous joints are actually the first to really kind of become hard and stiff. Cartilaginous joints will change in the vertebral column. That's the reason why a lot of times as people get older, they kind of shrink a little bit because those cartilaginous joints compact and it makes the vertebral column a little shorter. Synovial joints will also lose elasticity. So it means with that loss of elasticity, the strength of the support of the synovial joints is also lost, which means you're more likely to have injuries in those areas. Which is a reason why a lot of times people's hips later in life have issues, people's rotator cuffs have issues. And again, the best way to kind of keep your joints healthy is just to use them regularly with very healthy weight-bearing activity. We're going to focus a little bit more on the knee because it's a really great example of all of the components of a joint. Plus, especially since you guys are in high school, there's a lot of knee injuries that you're probably going to come across or hear about in your lifetime. So we're going to know the knee in more detail than the other joints. So the knee is also one of our largest joints, which makes it really fun to study. It's one of the most complex. It has tons of ligaments connecting it. We'll learn about 4 in particular. It's also stabilized by a lot of tendons connected to our quads or our hamstrings. It contains menisca and bursae, so we'll learn about both of those. It's a synovial joint. It's classified as a diarthrosis, which means that it's able to move in 2 ways. And then it is a hinge joint. So we can see that the movement of the knee is that it's going to flex and extend. So we can see that very classic hinge joint. You can see on this animation that on the outside, I believe that's the lateral side of the knee, you can see that there's a really important ligament that connects the fibula to the bottom condyle of the femur. We can also see there's a ligament that's going to connect the patella to the front part of the knee. As they layer on the muscles, we can see that there are tendons that are going to attach to that top quadriceps group there. And then, of course, the hamstrings as well. All right. So just if we strip everything else away, we look at the bones involved in the knee, we're going to have the femur. And remember that these edges here, these 2 protuberances are going to be the medial and the lateral condyle they're found on the posterior side of the femur. We're going to have the tibia that makes the tibial plateau. And then we're going to have the fibula, and lastly, our little patella. So those are all the bones that are involved. On the anterior surface of the leg, we're going to have 4 major muscle groups. So these muscle groups are going to be on the very top. The center one is the rectus femoris. Rectus femoris. If we move to the lateral side, so just outside of that, on the lateral edge is going to be our vastus lateralis. And then on the inside, aptly named the vastus medialis. Then we have this sartorius muscle that will kind of make this diagonal sweeping motion. You can see that this muscle kind of goes on the outside of the knee. This is a stabilizer muscle. So your sartorius is very, very important if you're an athlete to stabilize the joint of the knee to make sure it doesn't go side to side. On the posterior side, so we're looking at the back of the leg now, there are also 4 muscles that help to move the knee and to stabilize the knee. The first is the gastrocnemius, which is another name for the calf muscle. That's going to help support the bottom part of the tibial plateau and the fibula. Then we have the semitendinosus and semimembranosus. So that would be this one here as the semimembranosus, and the semitendinosus would be the one on top of that. Good way to remember this is tendinosus is a skinnier muscle. Sorry about that. So again, you can differentiate the semimembranosus and the semitendinosus. The semimembranosus is a thinner, wider, flatter muscle that goes underneath, so deep to the semitendinosus. The reason why I bring this up is that we're going to see this in the cats later this year. So both of those are going to help with the flexion of the knee joint along with the biceps femoris. Really good way to remember that is that the biceps femoris is going to do the same thing that our biceps and our arms do to make that angle a little bit more narrow. So it's going to help with the flexion of that knee joint. Okay, so other structures, the articular cartilage is on this image, is that darker cobalt blue. That's going to be the stronger cartilage that really bears most of the impact of the weight of that knee coming together. Then you can see these kind of lighter greenish blue shapes on either side of the bone here. And of course, this is looking down at the tibial plateau. Those are the 2 menisci. So there's a medial and there's a lateral, and those are going to hold the condyles of the femur kind of on the head of the tibia. Then there's going to be a bunch of bursa. So specifically, there's a suprapatellar and an infrapatellar. So supra means above, infra means below. So these are the infrapatellars. These are the suprapatellar bursa. And then there's going to be prepatellar bursa, which is in front of it. So that's the one that you can kind of feel if you put your finger on the patella and you wiggle it back and forth just under it. You can feel your prepatellar bursa. And all of these, again, are going to cushion those really strong tendons that are connecting your quads and your hamstrings over those bones. So it's going to cushion them. Remember, if you have impact to that knee and it's like direct repeated trauma to that knee through a sport, or if there's one big blunt traumatic event, you can tear your meniscus, and we'll see what that looks like a little bit when we get into dissections and we see it. So those are all kind of like the structural muscular components, but let's talk about the ligaments that help stabilize the knee. So there's going to be a ligament on either side. The one on the inside is going to be the medial collateral ligament. So we can see that on the right-hand side of the knee image. And then the lateral collateral ligament is on the other side. So that's going to stabilize the knee, kind of looking at it from the front. It's going to stabilize it so the knee can't move left and right. And then we're going to have the ACL and the PCL. And these are probably the ligaments you've heard about before. These are inside of the knee. They are between the tibia and the femur, and they are going to fit into the groove between the condyles of the femur. The ACL and the PCL, which are the anterior and posterior cruciate ligament, those are going to be in charge of making sure that the femur and the tibia stay aligned when that knee is weight bearing. The way that you tear or you injure your ACL or PCL is if you are bearing weight on your knee, and typically you are twisting. That twisting motion is going to put a lot of tension on that ACL and it's going to end up tearing. So this is an actual cadaver picture of the posterior side. So we're looking at the back of the knee. You can see the medial and the lateral condyle of the femur. And you can see here we're looking at the PCL, which is the posterior cruciate ligament. And the ACL, you can see the very tip of it, that would go behind this posterior and connect to the other side of the tibial plateau. If we look at the anterior view, now this is the anterior view when it's flexed. So this is a bent knee looking at the very bottom of the femur. So the femur on top here, that would be the bottom part of the femur. Those are the two condyles. And we can see when it's bent back, here is the ACL and here is the PCL. All right, so you can see that all of those are kind of help stabilizing the knee. Now, here is a skeleton of the pig, and we are going to try to do a dissection of the rear pig leg. Because after much trial and error and research, we found out that the pig has the most synonymous and homologous structure of a knee to a human. So what we're going to be doing is I work with my butcher, and we're going to try to get this back knee part here. You can see the homologous structures. Their femur, although it's a lot shorter than ours, still has the condyles. They still have a patella. They have a tibia, they have a fibula, where it really starts branching off and not being completely homologous to a human is with the feet. So if you think about it, this a lot of times is confused as a pig's knee, but this is actually their ankle bone. And their metatarsals are very long, and they actually walk on their fingers. They walk on the phalange bones. If you look at this one that sticks out, you might say, that looks really weird. But that's actually just their calcaneus, and that's going to be where their gastrocnemius or their Achilles tendon connects. So we're going to see whether or not we can't have a good dissection and learn a little bit about the knee. We should be able to see bursa. We should be able to see tendons and ligaments. We should be able to see ACL and PCL. And the really cool thing is you can see the meniscus in the pig joint as well. So that is coming up with our dissection. I hope that this was helpful, and I'll see you in class.